Welcome to the Connecticut Orthopedics Continuing Education course on Management of the Rotational Athlete, presented by Chris Miller, Lauren Fiore, and Kristen Cohen. The course objectives are to outline common rotational sports injuries, discuss the evaluation of rotational sports injuries, discuss the treatment for rotational sport-related injuries, and familiarize yourself with return to sport progression for rotational sport athletes. Next, we're going to talk a little bit about the epidemiology of golf injuries. There's a lifetime incidence of over 50%, so more than half of golfers will sustain some type of injury over the course of their golfing career. Annual incidence varies a ton between what studies you're looking at. Some have incidence rates as low as like 15.8% and up to as high as 41%. One study reported about 2.5 injuries per 1,000 exposures. One exposure was considered 18 holes of golf. This is a pretty low injury rate, so golf is a relatively safe sport for most people. Injuries are not typically happening all that frequently, and they're not resulting in huge time loss. Injuries are more common in males over 60 years of age. I'm sure many of you have seen this in clinic. 25% of golfers, so over a quarter of golfers, are over the age of 65, and 75% of golfers are male, though there are more females participating in golf every year. The injuries that we see vary between professional and amateur golfers. The injury rate is actually higher in professionals, which is not necessarily unexpected given that they're swinging the club harder and more often. And also, pros tend to have more lumbar spine, hand, and wrist injuries. Amateur golfers actually tend to sustain more elbow injuries. Again, this does vary somewhat depending on what study you're looking at, but the types of injuries we see in different populations does vary.
So when looking at the different types of injuries we may come across with people who play tennis, typically the more acute injuries are lower extremity related. So that's when we'll see more of like that ankle sprain. And then if it's an upper extremity injury, it tends to be more overuse related. So those are your rotator cuff tendonitis, lateral epicondylitis, and whatnot. And generally, about 84 to 88% of all tennis-related injuries are related to the muscle or the tendon. And serves tend to put the most demand on the body. So it's the most demanding aspect of tennis, and it accounts for majority of the strokes throughout a match. So 45 to 60% of all strokes in a match are serves. So generally there's only about 210 strokes per match, and 120 of those are possibly serves. So if somebody's biomechanics are off during their serve, the shoulder and the elbow could be more prone to an injury. So especially with more novice players or people who play recreationally, they're a little bit more prone to developing those upper extremity overuse related injuries. So any sort of muscular imbalance from the lower extremity or core can also then affect the kinetic chain and increase risk of injury as well. Now, when looking at pickleball, it's a little bit different, and we'll get to the differences between pickleball and tennis a little bit later in this presentation. But pickleball is relatively up and coming. It's becoming more popular over the past couple of years or so, so we're seeing more pickleball-related injuries. And because it's relatively recent, there isn't as much data available looking at the epidemiology of pickleball-related injuries. But there was a study that showed the median age was around 68 years old. It looked at different pickleball injuries in the emergency department. 90% of those injuries happen to be with people greater than 50 years old. The injuries tend to be evenly distributed between both male and female, so one wasn't more common than the other. And then it also showed that strains and sprains were a bit more common. So because of that, lower extremity injuries were a bit more common than upper extremity. Because like I mentioned in the last slide, those acute strains or sprains tend to be a little bit more lower extremity focused versus upper extremity. So now in this chart, it takes a closer look at the breakdown of different injuries occurred playing pickleball, specifically in the geriatric population, just because pickleball has been a very up-and-coming sport with the older population. But about 63% of injuries were due to a slip, trip, fall, or dive. This was the most common injury overall. About 33% of injuries resulted in a strain or a sprain, which was more common in men, whereas 28% resulted in a fracture, which was more common in women, and this could be due to The fact that women are a bit more prone to developing osteoporosis or osteopenia and whatnot. So when they have that slip, trip, fall, or dive, it could result in a fracture versus a strain or a sprain.
So we've talked about some of the risks associated with playing golf as it relates to injuries. Let's talk a little bit about some of the benefits of participating in golf. One study found improved physical health, improved mental well-being, and a potential contribution to increase life expectancy as some of the benefits for golf. Golf can also be used to meet the physical activity guidelines recommended for Americans, which, just as a reminder, is at least 150 minutes of moderate intensity aerobic activity per week, or over at least 75 minutes of vigorous intensity aerobic activity per week. And then 2 days per week of moderate to high intensity strengthening, whole body strengthening, that is, per week. Some of the benefits of meeting the physical activity guidelines include decreased levels of anxiety and depression, increased bone health, improved quality of life, decreased risk for heart disease, type 2 diabetes, hypertension, dementia, and certain cancers, better sleep, improved cognition, and decreased obesity and obesity-related health conditions. This is not an exhaustive list, so there's obviously some significant benefit to meeting the physical activity guidelines, and golf can be one method of at least meeting the aerobic component. Again, that's 150 minutes of moderate intensity physical activity per week. And again, I want to highlight the word at least. We should be shooting for, at minimum, 150 minutes, and if we can do better than that, great. One round of golf, if you're walking, can check that box for you for the week. Not that you should necessarily aim to stop there, but for a lot of our patients, they're going to have difficulty meeting those physical activity guidelines, and if they can be participating in something that they enjoy that allows them to meet those guidelines, there's a huge health benefit to that.
So now we're going to take a look at the benefits of playing racket sports. So it's been shown that tennis helps to improve aerobic capacity, increase bone density, decrease body fat, increase muscle strength, as well as reduce cognitive decline. It can also help to decrease the risk of developing a systemic condition such as diabetes or cardiovascular disease. This helps somebody increase their number of daily steps, as well as increases someone's overall activity level. And most importantly, it provides somebody with a sense of community. So it helps to encourage social interaction, decrease feelings of loneliness, and it reduces stress levels. So especially with our pickleball population too, since this tends to be a bit less physically demanding than tennis, it helps keep the older population a bit more active and engaged in the community. So it benefits both their physical and their mental health.
Next, I want to talk a little bit about the mechanics of the golf swing. We have the golf swing broken down into stages here. How we break it down does vary a little bit depending upon who you talk to, what study you're looking at, but I think this is a relatively easy way here to think about the golf swing. And it helps to understand the positions, the ranges of motion, what types of strengthening we might need to do with patients if we understand this well. So the first one is address. This is one where there's the patient or the golfer is just standing over the ball. We have slight hip flexion, soft knees, relatively neutral ankle position, arms hanging down in front of us. So there's some slight shoulder flexion there, but that's really all passive. Early takeaway is when we begin to take the club behind us, and it goes from hands down in front of us to hands at waist high. We'll start to see some external rotation in the trail shoulder here. We're getting some rotation through the lower body, the lumbar and thoracic spine, and some horizontal adduction of the lead shoulder. Then we go to the top of the backswing. This is from the hands at waist high until we reach max rotation. Again, we're getting more trail shoulder external rotation, more horizontal adduction of the lead shoulder, more rotation through the hips and lumbar spine. We get some rotation through the rest of the lower body as well. Wrist should remain relatively neutral. Lead elbow should be extended. We have about 90 degrees of flexion in the trail elbow at this point. And relatively speaking, we have some rotation towards the lead side or towards the target of the cervical spine at this stage. Transition is when we begin to move towards the ball from having moved away from the ball. So this is an important part of the swing here. All of that rotation that we've built up, that coiling that we've done to get to the top of the backswing, we're now unwinding down towards the ball. As we get into the downswing, again, all of that stuff that we talked about on the way back, we are undoing. So we are seeing rotation through the hips, so internal rotation of the lead hip, and external rotation of the trail hip. When we were seeing the reverse through the backswing, we're starting to see that externally rotated trail shoulder start to unwind towards the ball. Again, wrists should be relatively neutral, and we're moving towards the ball again until we get to the impact position. Impact position is the only position that matters as far as what the golf ball does after you hit it. The way that you get there only matters insofar as it gets you to a good spot here. The golf ball doesn't know what the top of your backswing looked like. It doesn't know what the beginning of your downswing looked like. It only knows what the club path, the club face is doing when the ball is contacted. And this is important to remember because one of the big things that we're going to revisit throughout this process and throughout this course is there's a lot of good ways to swing the golf club. There's not one right way to do it. And then follow through. This is after contact with the ball. This is where we're seeing a lot of lead hip internal rotation, a lot of trail hip external rotation. We're seeing some horizontal adduction and flexion of the trail shoulder, some external rotation and flexion of the lead shoulder. We're seeing some internal rotation through the lower body, some left rotation through the lumbar and thoracic spine. And again, relative trail side rotation of the cervical spine.
So now when treating racket-related injuries, we need to have a good understanding of racket mechanics and what goes into playing racket sports. And specifically, we're going to take a look at the serve because the serve is the most physically demanding aspect of tennis. So we're going to take a look at the different phases. We have 5 phases. You have the wind up, the early cocking, late cocking, acceleration, and follow through phase. So you can see here the first image of the man in the wind up phase. So this is where the ball is being released. And during this wind up phase, you need to be in what's called the trophy pose. So if any aspect of your body is altered from what the typical trophy pose is supposed to look like, it could result in injury. So you want to make sure upper extremity, trunk, lower extremity, everything is in the ideal situation to set you up for success when going to serve. So following the wind-up phase, we have the early cocking phase or the loading phase. So this begins from the point of ball release to the point of maximum load in the lower body. And this is the point of maximum knee flexion. So this is kind of where it's connected. So in your wind-up phase, if you have what's called an S posture, or what we typically refer to as anterior pelvic tilt, maybe just due to core weakness or trying to get more power by extending the back, but really you're just going to injure your lower back because you're not necessarily using your legs as much as you should be to get that explosive power when going to serve. And then going on to the next phase, we have the late cocking phase. So this spans from the end of the loading stage to the point of maximal shoulder external rotation, which leads into the acceleration phase, where your power comes into when you're starting to hit the ball. So this is when your internal rotators are concentrically contracting, and you're trying to increase your speed and increase your intensity as you make contact with the ball. And then lastly, you have your follow through or your decelerization phase. And this is the point where the upper body and the lower body have finished decelerating. So during this phase, your eccentric control of your external rotators is going to be super important. Similar to any overhead sport, your rotator cuff is needed to stabilize the shoulder when exerting this force overhead to increase one ball speed while also preventing injury or overuse to the shoulder. Some other key players when looking at ball speed in the kinetic chain are going to be your rector spinae muscles, latissimus dorsi, triceps, pec major, and extensor carpi radialis longus and brevis. So next we're going to highlight some key differences between tennis and pickleball. So there are many similarities when treating racquetball injuries. However, the mechanics behind tennis and pickleball can vary because there are some key differences that we're going to highlight now. So when looking at the court size, first of all, tennis courts are much larger than pickleball courts. So this is going to change up the aerobic demands of the sport. So tennis courts typically measure around 36 feet wide by 78 feet long, whereas pickleball courts are only about 20 feet wide by 44 feet long. Pickleball courts also tend to have shorter net heights. So tennis courts, typically the net is around 36 inches high in the middle and 42 inches high towards the posts, whereas with pickleball, the net's only around 34 inches high in the middle and 36 inches high at the posts. Pickleball also has a non-volley zone towards the center near the net called the kitchen, and it extends about 7 feet from the net on both sides. So typically, when you're playing pickleball, you cannot hit the ball within this kitchen zone. Next, we're going to take a look at the different rackets. So a tennis racket is going to be much larger and heavier than pickleball paddles. Pickleball paddles tend to be more lightweight, as well as the pickleball itself. You can see here, the pickleball is perforated, whereas the tennis ball tends to be a little bit more dense. And being that the tennis racket is larger, heavier, and the tennis ball is more dense, it's going to change up the type of force or ground stroke required to return the ball when playing a match. It's also important to note that serving strokes are going to be different when playing tennis versus pickleball. So as highlighted in the slide prior, when breaking down the serve mechanics, this is only really applicable to tennis. With pickleball, the serves tend to be underhand and you aim toward the opposite diagonal of the court, whereas with tennis, it's typically going to be that overhand and you're aiming for that trophy pose that I was talking about, again, in that slide prior. So overall, exertion levels are going to be much higher when playing tennis versus pickleball, which is why we see a lot of the older population favoring pickleball over tennis, because they're able to participate in pickleball a little bit more easily than they would with tennis.
Let's talk a little bit about mobility requirements for the golf swing. For a long time, mobility was thought to be one of the most important traits to have for a good golf swing, especially for generating speed and subsequently generating distance. A lot of the newer research has kind of contradicted this. The thinking a long time ago was a big backswing allows a lot of time to accelerate and to thus be moving more quickly when we get to the ball. The ball's going to travel further. There's some research, like I said, that now kind of contradicts this. There are, as I said in the mechanics slide, a lot of ways to swing a golf club successfully. It is probably true that strength and power are much more important for club head speed and distance, according to the current literature. All of that said, you're going to get patients that come into your clinic that are looking for or think they need more mobility in order to swing the golf club more effectively, in order to hit the ball further, because that's what they've heard for a number of years. I know I see this frequently. So looking at some numbers as far as biomechanical norms for the golf swing, we see torso rotation between 78 and 109 degrees in one study, with pelvic rotation between 37 and 64 degrees. I think one of the big things to note here is that there is greater torso rotation than pelvic rotation. That is something that you'll hear called the X factor, and that is one component that does appear to have an impact on the ability to generate club head speed. Basically, how much is a patient able to separate their torso from their pelvis in rotation? And the distance between those 2 points does seem to have an impact on club head speed. Basically, how much are we able to separate our T-spine from our pelvis? And this is important, especially at the start of the downswing and in transition, because it allows us to take advantage of the stretch shortening cycle to generate more speed. The X factor is the only mobility component that has been demonstrated to be correlated with a lower handicap. That is something I'll mention throughout this course is handicap. For those of you that don't know, handicap is a measure of how well your potential to score in golf. And so a lower handicap is indicative of a generally better golfer.
So now we're going to look at mobility related to racket sports. Now, when talking about mobility, we also need to talk about stability, as they kind of go hand in hand. So as you can see here in the image provided, our mobile and our stable joints typically alternate one after the other. So, for example, our shoulder is obviously an extremely mobile joint. With racket sports, the player needs to have a substantial amount of shoulder range of motion to perform serve and ground strokes with proper form. However, similar to throwers, we'll typically see a decrease in shoulder range of motion, especially on the dominant arm and especially with internal rotation. So, similarly, when looking at players with elbow tendinopathy, it was found that these players demonstrated decreased shoulder internal rotation and wrist flexion. So, both the shoulder and the wrist are meant to be mobile joints, and with the loss of this motion, there's going to be more stress placed on the stable elbow, and we'll see a resultant injury there. Another mobility issue we may see with tennis players is decreased hip rotation, along with tight hamstrings, quads, and hip flexor mobility. Decreased mobility here may make someone a little bit more prone to developing a lower extremity injury. And now looking at this slide, this table just further depicts the glenohumeral internal rotation deficit across tennis players. So you can see here how the dominant shoulder has quite a bit less internal rotation range of motion versus the non-dominant shoulder. However, the total range of motion between both upper extremities is actually relatively similar, as the loss of internal rotation is made up for with the external rotation.
Next, we're going to talk about stability in the golf swing. There's demands on both the upper and lower extremities as far as stability goes. In the lower extremity, it's a little bit more straightforward. We're talking a little bit more about balance. When we're in our backswing, we have about 80% of our weight on our trail leg. And when we get to our follow through, we have up to 90% of our weight on our lead leg. There's a certain amount of stability required for this. One study did find that golfers who had better balance trended towards, or was correlated with, having a lower handicap. Again, lower handicap being indicative of a better scoring golfer. The lower extremities are really important because, again, this is where the energy transfer comes from. We need a stable surface in order to push and twist from, in order to generate club head speed to put through the ball. So lower body stability is going to be really key for all elements of the golf swing. I think sometimes under-recognized is the stability demand on the upper extremity, most notably into the wrist. The wrist is going to be a mirror of the club face. If we flex the wrist, the lead wrist that is, it's going to tend to close the club face. And if we extend the lead wrist, that's going to tend to open the club face. The reverse is true for the trail wrist. The reason this is important is opening and closing the club face is going to have a huge impact on how straight the ball flies. The more neutral we are, the straighter the club face is relative to the path coming into the ball, the more likely we're going to hit a straight shot. Just to give you an idea of the extent to which this matters, on a 250-yard drive, 1 degree of either closed or open club face relative to the club path or swing plane can result in 15 yards of left to right dispersion on either side. So a 30-yard dispersion if you're 1 degree flexed or 1 degree extended. So I think that just underlines how huge the stability of the wrist is, and even more than just stability, proprioception specifically. If we can keep track of where our wrist is throughout the swing, we're able to have an idea of where the club face is. And if we're able to control that more consistently, we're going to hit a lot more straight shots. So this is something that's going to be really important, working on proprioception and stability through both wrists in the golf swing.
Now, on the other hand, we also see injuries related to stability issues in racket sports. So, for example, our lumbar spine is a point of stability. However, if there is limited thoracic or hip mobility, which are supposed to be mobile joints, we may see some abnormal motion at the lumbar spine, therefore leading to a low back injury. In adolescents, decreased trunk stability has also been shown to cause lower extremity injuries. And then additionally, when talking about stability, improved core stability is going to be an essential component with racket players, as this is going to help with trunk stability as well as improve overall upper extremity performance.
Next, we're going to talk a little bit about strength and its importance to the golf swing. The most important thing that strength contributes to the golf swing and ultimately performance on the course is it's important for distance. Distance is correlated with a lower handicap. That is, people that hit the ball further generally score better. So what do we want to think about when we're trying to work on strength or evaluate strength for the golf swing? The first thing is specificity. Are we making sure that we're not just looking at the typical like flexion extension type of things, and we're looking at rotation, because rotation is a key part of the golf swing, obviously. And are we looking at the right muscles? The hips are going to be our big power generators through the golf swing. So let's make sure that we're taking a look at those hip muscles that contribute a lot of force to rotation, a lot of force to the golf swing, and ultimately how much force we're placing onto the golf ball. When we are working on strength with a golfer, we're trying to get them back on the course. Are we using high load or are we using low load? Now, there's a lot of ways to think about this, and the answer is we should be working on both. Low load is obviously going to be focused a little bit more on contraction speed. So when we're working on strength, we should be working on high load. Most golf swings, with the exception of shorter chips and putts, are a max effort event. So when we're training strength, we want to be working on max effort events. That doesn't mean we need to be doing a 1 rep max every single time we're working on strength for every exercise, but we should be using heavier loads. If we're trying to drive strength gains, we want to make sure that we're using heavier loads. Contraction speed. So are we thinking about, the component of the golf swing of how quickly are we able to move the weight? Now, the interesting thing here is that does not mean that we need to be moving the weight quickly with every single exercise that we do. Otherwise, we wouldn't be able to be using high loads, right? We should be focusing on max intention for contraction speed. In other words, even if the weight is heavy and it ultimately moves slowly, we want to try to move it as quick as we can. The intention should be to move the weight as fast as possible. So there's not a lot of benefit to, sort of holds or slow controlled reps necessarily with trying to work on golfers. We want to be working on faster and as fast as possible. Within reason, obviously, we want to be cautious. We want to control the weight. We want to have decent form. But we should be at least working with the intention of maximum effort. The next step is progressive loading. So a lot of times golfers are going to come to you, they have an injury, and they have probably never done any strength training before. We discussed in an earlier slide talking about mobility, that for a long time that was a huge emphasis for golf fitness, was mobility. We needed to be able to move further. Now that more research has come out relating to golf fitness, we've kind of come to realize that that's not really as important as we once thought. There is a baseline of mobility that's required, but it's not something that we should be spending hours upon hours doing. That said, many of the golfers still do that, so they haven't done any strength training. What that means is they're going to come to you in a relatively untrained state. They haven't done any strengthening. You're the first person asking to do it. What happens when somebody's new to strength training is they pick up strength gains relatively quickly. The reason this is important is the things that you're doing with them in the first couple of visits are likely not going to be hard enough and shouldn't be hard enough in the next couple of visits. We should be able to kind of gradually add weight and add exercises relatively quickly with a newcomer. We're going to adapt much more quickly when something is really, really novel. And so when a golfer comes to you, they haven't done any strengthening, they've done a whole bunch of stretching and mobility stuff, and they can rotate for miles, but they don't have a great deal of strength. Again, those adaptations are going to come on quickly because it's new. And so we should be making sure that we're adding things relatively quickly and we're not doing the same things over the course of multiple weeks. And then the last piece is consistency. You can have the best strengthening plan for a golfer or for any athlete. And if we're not doing it consistently over long periods of time, the likelihood that we're going to make any significant adaptations is much smaller. I think one of the things that we can do here to help with consistency is to make sure that we're relating it back to the thing that they want to do. So making sure in this case that we're relating it back to golf. This is going to help you with X, Y, Z. This is going to help you hit the ball further. This is going to help you with this shot or that shot, or do this thing that you've been struggling with. And then also make sure they don't absolutely hate every single exercise that you give them. Try to kind of meet them in the middle, find some things that they at least somewhat like doing, and again, relate it back to their sport, their passion, their goals.
So now we're going to talk about some of the strength requirements for racket sports. So when playing racket sports like tennis or pickleball, much of the strength needed during serve and ground strokes is going to come from the upper extremity. So the strength is needed for ball velocity, as well as to reduce injuries and protect the joints, muscles, and ligaments. So the key players when it comes to racket speed are going to be the muscles contributing towards shoulder internal rotation, wrist flexion, shoulder horizontal adduction, and forearm pronation. And these are listed in order of importance here. So if we're treating a racket sport player with weakness in any of these planes, it's going to be pretty important to address. It's also important to note that grip strength and endurance is essential for added wrist stability while playing tennis or pickleball.
Next, we're going to talk about the importance of explosiveness in the sport of golf. Explosiveness comes as a progression off of the base of strength that an individual has. In other words, explosiveness is the amount of force that somebody can generate in a defined period of time, especially in a short period of time. So the amount of force that you can generate in a slow rep, in a more strength-oriented environment, has an impact on the amount of explosiveness you can deliver. If we have the ability to generate more force, it's now just a matter of being able to generate that force in a shorter period of time. So with that in mind, the downswing in a golf swing lasts about 0.3 of a second. So how much force can we get to the club head and then ultimately to the ball in 0.3 of a second? The more force we're capable of generating generally, the more force we're probably going to be able to fit into that short period of time. Now, there are certain things that we can do to help deliver that force more quickly. So you don't necessarily have to get stronger to improve your explosiveness. You can improve the percentage of your overall force capability that you can generate in a short period of time. And the ways that we're going to be able to do that are with high effort, really fast exercises. This is important in golf because it has a huge impact on club head speed, which also ultimately has a big impact on distance. We discussed before that golfers that hit the ball further generally are going to score better. So this is really important for any golfer that cares about what score they're shooting when they get out on the course. So what kind of things do we want to do or focus on to train explosiveness? It's obviously going to be really high effort. Most golf swings, with the exception of putts and pitches and chips, are going to be max effort events, or at least 90% effort events. How many reps should we be doing? Well, we want to think a little bit about specificity here. Golf swings generally are one-off events. You do a 90%, 95% max effort swing, and then you go to wherever the ball landed, and that can take minutes to get there. So it's not like you're having to string together a whole bunch of these in a row. So we don't need to perform sets of 10, 15 reps in order to train for the golf swing. We need to stay a little bit more specific. That doesn't mean we need to be doing single reps either, but we want to keep the general rep count low. And then what about volume? So how many of these are we going to do? Well, some of that's going to depend on the individual in front of you. And again, we want to think about what are the limitations of this person. So do they find that they play worse as the round goes on? Is there maybe a fatigue component that is contributing to a decrease in performance over time? If so, we maybe want to increase the volume a little bit. Or is this somebody who is pretty steady throughout the round, but they're just not very fast. They're not hitting the ball very far. We probably don't need to do a lot of reps in order to drive progress here, because a lot of what drives gains in explosiveness is going to be neurologic changes, not necessarily structural changes. So we can see these adaptations occur a little bit more quickly than we can with strength gains in a lot of cases, where we need some structural changes to occur, which just take time. That's the way the body works. So we probably don't need a high volume in somebody who's pretty steady but just wants to pick up a little bit more club head speed. We don't need to be doing hundreds of reps per workout multiple times a week. Maybe a total of somewhere between 20 and 50 reps or twice a week is going to be enough to drive progress for that person. One of the other tools that I want to highlight that can help with improving explosiveness is something called post-activation potentiation. You may have heard this term before, but basically what this involves is doing some type of high effort strength exercise and then following it with a plyometric movement that has a similar makeup. So one example, an easy one before we dive into the more golf specific ones, might be doing a really heavy barbell squat, then counter movement jump or vertical leap test. What we find is by doing that heavy rep first, the nervous system kind of gets primed to perform better in the subsequent plyometric activity. And so we can actually add inches instantly to somebody's vertical leap by doing a really heavy rep of strength exercise first, or several reps set of strength exercise first. So this is something that we can use. We can do some heavier exercise and follow it up with faster contractions. One of the things that I want to talk about here as well is there is this idea that in order to improve club head speed, we need to just do something that exactly mimics the golf swing. And that is helpful. There are a number of systems out there, a number of products out there that are designed to help people swing more quickly by swinging some type of implement as quickly as possible. And that is helpful. That said, we can get a lot of speed gains, explosiveness gains, by doing regular explosiveness stuff, regular vertical jumps or ball tosses, throws, those types of things all will help improve club head speed. And there's a good chunk of research out there on this. So different throwing things, medicine ball throws, those types of things, box jumps, those types of exercises all help improve explosiveness. Remember, most of the force that gets placed into the golf ball is coming from the hips, and it has to go through the ground first. So things like vertical leaps and box jumps actually improve club head speed, and this has been pretty well borne out in the research. So don't think that you have to come up with some crazy elaborate setup in order to work on turning the body really quickly, just like a golf swing. That said, the easiest way, if you want to work on some of that rotational stuff, you think it's something that your patient will benefit from, medicine ball type exercises tend to be the best way to go. It's low equipment need. Space is a little bit more of a concern in that sense, but beyond that, those are pretty accessible, and most people can find a way to do some of that.
So when talking about the strength requirements for racket sports before, we were primarily talking about the upper extremity, but now when it comes to the explosiveness aspect of racket sports, it's going to be primarily lower extremity focused. So the lower body is going to be essential when discussing the explosiveness needed to play racket sports. And I want to specify that most of the slide is going to be referencing tennis, as pickleball doesn't require as much explosiveness as tennis due to the smaller court size. So they're not going to have to get from one side of the court to the other as quickly as with tennis. So tennis is an intermittent sport where it's very fast-paced, has a lot of stopping and starting. There's going to be dozens to hundreds of short explosive bursts per match. So between all the serve and the ground strokes, there's a lot of movement occurring on the court. All these strokes are going to require rapid changes of direction and the ability to get from one side of the court to the other. And generally, this is going to require a good amount of fast twitch muscle fiber recruitment. The sport is also pretty unpredictable in nature. So between the point length, shot selection, match duration, weather, and the opponent, all these variables can affect performance. So in general, the average point length was shown to be around 6.39 seconds, which demonstrates how fast-paced this sport can be. However, I want to mention that the article referenced here when finding this information was performed on professional level tennis players, so this may vary recreationally.
Let's talk about regional interdependence in the golf swing. This is a crucial part of effectively treating this population, and so it's going to be really important that we understand how to evaluate these patients with keeping regional interdependence in mind, as well as it's going to drive treatment in a really big way. We really need to assess the whole person here. And so just to illustrate this, I have a question here. Why may you want to look at hip mobility in a golfer coming to you complaining of right shoulder pain and a history of right shoulder surgery? Go on to the next slide for my thought process there and what I think is a reasonable way of approaching this. So why might you want to look at hip mobility in a golfer coming to you complaining of right shoulder pain and a history of right shoulder surgery? Well, maybe saying it another way will help understand this a little bit better. Why would you want to look at both the hip and the shoulder in a sport requiring a great deal of rotation? I think that helps illustrate why that might be important, just reframing the question a little bit. Basically, in order to get depth in their backswing, in order to get the club behind you, you need to rotate from somewhere. Might be from the shoulder, might be from the hip, might be from the lumbar spine, might get a little bit of rotation from the knee or the ankle. There's a lot of different ways that you can do it. You can change foot position to get more rotation and more depth in the backswing. But if somebody's coming to you with right shoulder pain, it's possible that their trail hip doesn't internally rotate very well. And so their right shoulder, let's say this is a right-handed golfer, their trail shoulder has to externally rotate further to get the club far enough behind them for them to feel like they have an effective backswing. So they're trying to offload a hip that's really stiff by getting more rotation from a shoulder, and this shoulder, in this patient's case, previously had surgery. So maybe they used to get more external rotation from there, but they're a little stiffer now post-surgically. And so they're kind of hammering into and trying to achieve range of motion that they just don't have. And instead of directly attacking and just hammering a whole bunch of external rotation stretching on that right shoulder, maybe we would be better off seeing if we can gather a little bit more rotation from the hip. This is just one way of illustrating this. This is true throughout the body. It's not just the shoulder and hip that are related. For example, one study found that subjects who had developed low back pain playing golf actually had less hip rotation. So again, we're coming back to the hip in that case. But the development of low back pain can be related to hip mobility, as that study showed. The bottom line here is we need a global assessment. We can't just look at the body region that person is coming to us for. We can't kind of hone in on just one small thing. There's going to be a lot going on here. The thoracic spine is going to influence the shoulder, is going to influence the hip, the knee, the ankle. For example, if a golfer has limited dorsiflexion on their lead side ankle, they may struggle to get depth in their backswing because we need some close chain dorsiflexion to get back there. So that golfer may wind up with some back or some knee or some hip or some shoulder issues because of a lead side, left side, in the case of a right-handed golfer, dorsiflexion limitation. So even though it seems pretty remote to the area that may have developed a problem or may be exhibiting symptoms or pain, we should really make sure that we're looking at the whole person whenever somebody comes to us with pain related to golf or any rotational sport. We are going to talk a little bit going forward here about specific ways to make sure that we don't miss anything and systematic ways to ensure that we're assessing the whole person and not dropping the ball and missing something that may be an easier fix for us to help alleviate our patient's pain.
Now, similar to golf, when treating a racket player, we need to look at the whole person, not just the injured joint, as an issue with one joint can affect the entire kinetic chain. For example, what do we see here in this image? So on the left side, we're going to see the optimal trophy position that I've mentioned earlier in the presentation. But on the right, you could see how there's decreased trunk rotation, as well as decreased shoulder mobility and wrist radial deviation. So when one joint demonstrates limitations, it may impact other joints. So as already discussed, when talking about mobility and stability, everything goes hand in hand. So his decreased shoulder mobility may also lead to a lack of trunk rotation or spine dissociation when preparing to serve. With any rotational sport like golf or tennis, it's extremely important to be able to dissociate the upper extremity and lower extremity.
Let's talk about common golf injuries. We're going to touch back on some things that we talked about in earlier slides and then expand upon it a little bit here. We talked about the most common sites of injury are the upper extremity and the spine in golf. There's some variability between professionals and amateurs. Seems like wrist and hand injuries are a little bit more common in the pros. And it depends on which study you're looking at, but either the spine or the elbow is the most common injury site in amateurs. This last bullet point is one that I think is really important and the area where I want to expand on things a little bit, which is that the vast majority of injuries in golf result from overuse. The reason this is important, I think, is certain injuries are hard to prevent or prepare for or lower the risk of. Traumatic injuries like you might see in a sport like football, for example, if you just get hit the wrong way, no amount of preparation would likely have prevented that injury. Overuse injuries are a little bit of a different story. We can prepare the body to handle or tolerate the demands of a sport like golf such that we should be able to decrease the risk substantially in an already low risk sport of injury. we need to be able to think accurately about what those demands are and know where those overuse syndromes tend to develop. So I do think we have a fair amount of control over the injury rate here. It's never going to be zero, but I think we can drive it down even further than it already is. We just need to know where to spend our effort. So we have some data here, like I said, upper extremity in the spine, elbow and spine in amateurs, probably wrist and hand in professionals. That said, we still need to look at the individual in front of us. And one of the things that is hammered home in the TPI training, the Titleist Performance Institute training that I took some years ago, is assess, don't guess. So we want to know where to spend our time in order to get the most benefit for the individual in front of us. So we want to make sure we do a thorough assessment. Like we talked about previously, we're looking at them top to bottom, whole body. We're not just kind of zoning in on, okay, the shoulder hurts, so we're going to look at the shoulder. And we're going to use an assessment to guide our intervention to help manage the current injury and prevent further injury down the road. So coming up here, we're going to talk about the assessment, how we can do that, and how we can make sure that we're spending our time effectively. I had mentioned before, a lot of times, golfers just by default spend time working on mobility when that might not be the spot that they need to be spending their time. It also might be, but it's good to know for sure. So the assessment that we're going to go over is going to help kind of illuminate where time will be best spent and what will be the most efficient use of our time. So we're not spinning our wheels doing things that ultimately are not going to have a big impact for us out on the course.
So now we're going to take a look at some of the more common injuries we may come across with people who play racket sports and the mechanism behind those injuries. First, we'll take a look at upper extremity, and then in the next slide, we'll talk about some lower extremity and trunk injuries that you may come across. So first, with the shoulder, more often than not, we'll come across internal impingement syndrome and slap tears. And this is due to the high intensity repetitive overhead activity related to racket sports. Next, when looking at the elbow, we have our lateral and medial epicondylitis, so our tennis and golfer's elbow. And typically, lateral epicondylitis is due to backhanded strokes with the wrist flexed. So we need to strengthen ECRB, ECRL, so it's able to counteract that wrist flexion during those backhanded strokes. And then with medial epicondylitis, usually there's excessive wrist snap on serves, or open stance hitting, short arming strokes, and whatnot. And these are both more common in recreational players because they don't have that feedback from professionals to change up the mechanics of how they're hitting the ball, so they get that repetitive stress and overuse of certain muscle groups. And then lastly, a little bit more distally, looking at the wrist, we may see ECU subluxation or ulnar-sided wrist pain, or TFCC injuries or whatnot. And this is typically resultant from ulnar deviation in the non-dominant hand during backstroke or low forehand swings. So this causes sudden wrist flexion and ulnar deviation when swinging the racket, causing stress to the TFCC complex along the ulnar side of the wrist. So next, we're looking at the lower extremity injuries. So the number one most common injury related to racket sports are ankle sprains, and this is due to the repetitive jumping, running, twisting, pivoting required for tennis and pickleball. Then we also have meniscal knee injuries and hip injuries that are also due to the same jumping, running, twisting, and whatnot. With hip injuries, it could also be due to external rotation during forehand stroke. And then lastly, we also have lumbar strains and degenerative disc pathology. And this could be due to rotational forces and hyperextension during the serve. So if somebody has a weaker core, their lumbar spine is hyperextended during the serve, which we'll see more of like that S posture. They're going to be more likely to developing a low back injury. So now expanding on why these injuries occur, some common risk factors we see associated with the previously mentioned injuries are going to be prolonged play, experience and skill level, and their technique used. Novice players are going to be a little bit more prone to developing lateral and medial epicondylitis, like I mentioned before, due to kinetic chain inefficiency. Hand grip position on the racket may also make someone more prone to injury. A continental grip is ideal, whereas a forehand grip may make someone a little bit more prone to developing ulnar-sided wrist pain. During the lab component of this course, Kristen's actually going to expand upon proper grip position and whatnot. And then additionally, scapular dyskinesia and decreased shoulder flexibility, especially into internal rotation, again, as already mentioned, will make someone a little bit more prone to injury.
Next, we're going to talk about the various assessment tools that can help us evaluate rotational athletes effectively. A couple things to talk about here before we dive into those specific assessment tools is we can't just look at how much rotation somebody has or how much strength somebody has and that information is useful by itself. What we need to understand is what does the patient have and compared to what? Compared to what is necessary for their sport is the answer to that question. That's the reason for all the above things that we discussed. The TPI assessment that I'm going to talk about for golfers and the racket sport assessments were developed out of normative values for the sports. So looking at, in a golf swing, how much thoracic rotation, pelvic rotation, how much strength, stability, balance is required during the swing. And then these tools were developed to assess that so we can see if there's a deficiency. If we just know that they have X amount of degrees of rotation, that's not a terribly useful number unless we know that most golfers need around, whether it's X plus 5 degrees. All right, we're a little short. It's something we need to work on. Or X minus 5. All right, great. We got a little extra range of motion to play with here. We're not deficient there. This is not something we need to spend our time on. Like I discussed in the one of the prior slides, we need to know where to spend our time. And so that's what these assessment tools are going to do for us, is help illuminate where there might be limitations that are going to be affecting the golf swing or the swing of a racket or paddle, and where we have maybe areas of strength or areas where we have a little bit extra and we don't need to spend as much time working on that particular trait or characteristic. So next, we're going to talk about the specific assessment tool for golf. This is the Level 1 Titleist Performance Institute assessment. It just provides a general movement screen for a golfer. I'll go briefly through each of the tests here. There is some overlap, as one might expect, given they're both rotational sports, but there is some overlap here between the racket sport assessment and the golfer or TPI assessment. But to go through them briefly, we'll go through more detail in the lab component and actually do these on each other to see what we have as far as what traits or characteristics we might want to work on if we were playing or trying to work on getting back to golf. The first thing is you're just going to take a look at somebody's setup posture. We're just looking at how much lordosis, kyphosis, how much hip hinge, how much knee bend are we looking at here. The next one's the pelvic tilt. We're going to ask our patient to get into their setup position. We'll often call it a 5-iron posture. Imagine that they were holding a 5-iron. And then try to perform a pelvic tilt. You'd be surprised how many patients have difficulty dissociating their pelvis from the lumbar spine. I'm sure, we've all seen it in trying to teach a pelvic tilt just in hook lying on the table. It's even harder in the golf position. A lot of golfers really struggle here. Next one is going to be pelvic rotation. Again, we're going to see how does the pelvis rotate without the shoulders moving. Again, many golfers are going to struggle with this. And we discussed the X factor earlier. This is really important. How well can we separate our pelvis from our thoracic spine and our shoulders? So this can have a huge impact on the golf swing. Next, we're going to do the opposite, checking on torso rotation. Basically, how well can they rotate the shoulders without the pelvis moving? Again, a lot of limitations here, a lot of motor control and stability difficulties in separating the thoracic spine from the pelvis. So, and again, going to have a big impact on the golf swing, has an impact on distance, which has an impact on handicap. Next one is the lat test. Patient's just going to go down into a wall sit, palms facing each other, try to bring their thumbs to the wall behind them. Big thing here, keep their back flat against the wall. Obviously, if lat length is kind of what we're looking at here, if they extend their lumbar spine, they can gain a little bit of lat length and kind of cheat the test. We'll talk about ways to make sure that that doesn't happen. Next will be a lower quarter rotation test. Basically, you're standing on one leg here and turning one direction. You'll have the other leg down just for balance. turning one direction, switching legs, doing it on the other leg, basically checking how much mobility does their lower quarter have to rotate into their backswing, and then ultimately into their follow through. So we'll do both legs, both directions. We're looking at about 60 degrees as the goal number for this test. I'll show you how to set that up when we get into the lab component, but what we'll be using is what's called the lie angle of a club. A 6-iron specifically is about 61 degrees. So we'll use that. You can use a goni in clinic as well. It's certainly an option. The next one is going to be a seated trunk rotation. So the patient's going to be seated here, legs crossed. We're trying to take the pelvis out of it, and we're trying to see how well the trunk rotates. We're looking for about 45 degrees in each direction. Next is going to be a bridge with leg extension, basically a single leg bridge, and they're going to hold this position. Some of the things that you'll see with this particular test is hamstring cramps, a lot of shaking, not level pelvis. In other words, they kind of dip towards the non-stance side, or an inability to hold it for the prescribed amount of time. Again, any of those things are going to result in thinking that we need to work a little bit more on hip and lower quarter strength more generally. Next is an overhead deep squat. Most people have probably seen some variation on this, whether it's the FMS or not. We'll talk about, though, how that can impact the golf swing. Toe touch, again, just a hamstring general sort of flexibility test. The next one is the 90-90 shoulder test. So we're going to have a patient in 90-90 standing up tall first, and we're going to see how far they can externally rotate. Then we're going to have them get down into that same 5-iron posture we talked about for the first 4 tests and have them do it again. What we would like to see is equal amounts of external rotation in both upright standing and in the 5-iron posture. What we often see is that people are much stiffer in the 5-iron posture. The reason this matters is when you're trying to get into your backswing, if you lack external rotation in your golf posture, you're going to stand up at the top of your backswing. Now you've got to come back down and try to find that same posture on your way back down. It's another variable that leads to a tremendous amount of inconsistency in the golf swing, is that loss of posture in the backswing. So if we find that somebody is limited in golf posture but not in standing, that's definitely something that we're going to want to work on. There are also people who will have general just limitations in external rotation of that shoulder. And again, it's something that we want to know. Are they limited in both postures, limited in just the golf posture, is going to have an impact on how we are going to address that. The next test is a single leg balance test. It's pretty much exactly what it sounds like: hip flex to 90, standing on one leg and trying to hold it. Again, you'll be surprised at how many people have difficulty with this. It's important, like we discussed earlier with the golf swing, because about 80%, 90% of your weight may be on one leg during any given period in the swing. So something that we definitely want to keep an eye on. Cervical rotation. Again, there's relative cervical rotation. The head is mostly facing down at the ball throughout the golf swing, but the torso and trunk rotates underneath our head. And so we do have relative cervical rotation occurring throughout the golf swing. Next is forearm rotation. It's just going to be kind of pronation, supination. Wrist hinge, so radial and ulnar deviation. Again, this is going to have an impact on whether you're hitting the ball closer to the toe or the heel of the club. If we can't maintain adequate or appropriate radial or ulnar deviation, and we're having a lot of movement there, that can have an impact on where we're striking the ball with the club. And again, a lot of inconsistency can result there. And then again, wrist flexion extension. Similar to what we talked about on the stability slide, this is going to have a huge role in club face orientation. And if our club face is just a little bit more open or a little bit more closed, it's going to have a huge impact on which direction the golf ball is going to go, both which way it's going to start and which way it's going to curve, and ultimately where it's going to land, which is what everybody is after. So definitely something that we want to work on here. If we find some stiffness, they can't necessarily position their wrist in a certain way, they may not be able to hit the golf ball effectively.
So the course I had taken to learn more about racket mechanics and where this screen comes from is called Racket Fit. So it's the sister program to the TPI screen for golf, which Chris was just discussing. And this screen is made up of 12 movements, 3 of which are the same as the TPI screen for golf, as these are considered core rotary tests for any rotational sport. So I won't go into too much detail regarding those different movements since we'll be discussing it further during the lab portion of this course, but I'm going to briefly highlight the different tests. So the course I took to learn more about racket mechanics was called Racket Fit, which is the sister program to the TPI screen for golf, which Chris had just discussed. This Racket Fit screen is made up of 12 movements, 3 of which are the same as the TPI screen because these are considered core rotary tests for any rotational sport. And those 3 tests are going to be the pelvic tilt test, pelvic rotation test, and the seated trunk rotation test. So I won't dive into too much detail on those since Chris had already talked about those a little bit. So when you're doing the Racket Fit screen, first you're going to want to look at the serve grip. So the ideal grip is going to be the continental grip, which I mentioned already, and this is typically best because it'll make you less prone to developing certain injuries. The pelvic tilt test here is going to test mobility of the hips and the lumbar spine and their ability to control the position of the pelvis. So this is going to be critical in tennis for optimal power transfer from the lower body to the upper body during the serve or ground strokes. Whereas pelvic rotation, we're going to look at mobility and stability. So mobility, we want to look at the separation of bilateral hip mobility and pelvis to thorax separation, whereas with stability, we need to see if the person can stabilize their upper body and then freely mobilize their pelvis. So the head, neck, and trunk should remain relatively immobile. Right, now getting into the ones that are different from the TPI screen. So next we have the toe tap test down here at the bottom. So the toe tap test is going to assess hip internal rotation, which affects the loading stage of the serve. So the racket is placed in the middle of the feet, standing about shoulder width apart. Next, the person's going to internally rotate their hip to touch their toe to the racket. And now here you're going to want to look out for trunk rotation or an inability to touch the racket with the toe. So if the person is rotating their trunk, you want to stabilize their hips. And if they're still unable to touch their toe to the racket, it's going to be more of a mobility issue versus stability issue. To the right of the toe tap test, we have the single arm multi-segmental extension test. This is going to assess normal extension of the spine and hips while keeping the shoulder fully flexed. So if you're unable to, first of all, flex the shoulder to 180 degrees, so your humerus needs to cover the ear, it's already a failed test before you even start. But once you flex the humerus up to 180, you also have to do a little bit of like a back bend. And your ASIS is going to need to be in front of the toes, and the shoulder should be behind the heels. So with this test, you're going to want to look out for some trunk rotation, compensatory movements. Next, to the right of this, we have our shoulder 90-90 test. This is going to highlight any limitations in mobility of the glenohumeral joint and or the stability of the scapulothoracic junction. So it's essentially looking at the ability to fully externally rotate while the arm is in that 90-90 position. Our windshield wiper test is going to check for the ability to internally rotate the shoulder and pronate the forearm, turning the racket down. And I'll discuss more of the actual testing procedure when we're doing our lab component. To the right of this, we have forearm 80-80 test. This is going to take a closer look at forearm pronation. So if someone failed the windshield wiper test, you'll want to now assess forearm pronation, because the windshield wiper test looked at both the internal rotation of the shoulder and pronation of the forearm. So if we really want to isolate the forearm, you want to perform the forearm 80-80 test. Next, you have the wrist 80-80 test, and we're going to look at mobility of the wrist here. And this is going to be super important for proper set and release of the tennis racket. So with this one, the arm is in neutral at your side, palm is facing away from you, the racket's out towards the side, and then the person being tested is going to point their strings up towards the ceiling and then down towards the floor, essentially just flexing and extending their wrist, and you're looking for full wrist mobility there. Next, we have the side bend with arm raise test, and this is going to assess the ability to achieve proper trophy position. so that ideal serve position. If someone's able to do this, it's going to compromise their power and speed. Specifically, we need to look at trunk lateral flexion here, shoulder flexion, and shoulder abduction. Next, we have the wall squat. So the wall squat is going to evaluate the athlete's ankle dorsiflexion, hip, and knee mobility. So if either ankle is restricted, this can make it difficult to maintain a good posture throughout the release and loading phases of the serve. Next, we have the ankle rocking test. This is going to look at both ankle mobility and stability, specifically inversion and eversion. And this is going to be essential for those explosive movements, so the squatting, jumping, pivoting when trying to return the ball. And again, we'll talk a little bit more specifics about the test itself in the lab component. And then lastly here, the seated trunk rotation was that third of the one that overlaps with the TPI screen. So this is going to identify how much rotational mobility is present in the thoracolumbar spine. So we need that good separation between the upper and the lower body to help generate speed and maintain stable posture during serve and ground strokes.
Intervention for golfers is going to be something that we'll discuss a little bit more in the lab component, and we'll work through together a little bit more there. But I want to touch base on it here. And I think the important things to think about when we are designing our intervention plan for a golfer is, one, it needs to be tailored to the individual. We have said numerous times throughout this presentation that we need to assess, not guess. So we need to know what the individual's limitations are. There are some generic points that we can look at for golfers more broadly, but the person in front of us is the most important thing. So what are their impairments? And again, we need to look at the individual as a whole, not just the joint they've been referred to us for. We talked about how a shoulder problem can have a big contribution coming from something as far away as the hip or the ankle. So we need to make sure that we're looking at all of that stuff. And so what categories need work? Do they need more stability? Do they need more strength, explosiveness? Do they need more mobility? What are we looking at here? Where do we need to be spending our time? Because it's really easy with this population to spend a lot of time doing a lot of things and feeling like you're being really productive, and ultimately we're not getting any closer to getting them back on the course. And then the other big thing that we want to think about is, are we helping them by working on compensatory strategies or restorative strategies? So what do I mean by that? I mean, are there limitations that are just not going to be fixable? Let's say, for the example I had mentioned in an earlier slide, where we have some right shoulder pain in a patient with a history of a right-sided rotator cuff repair. It's a right-handed golfer, and they do have a little bit of a limitation in external rotation in that shoulder. The surgery was, let's say, 5 years ago. In that case, are we really going to hammer a whole bunch of external rotation, or are we likely to get a big chunk back that far out from the surgery? Maybe we'll get some, but we're probably not going to have a huge impact there. But patient has limited internal rotation in their right or trail hip. That's something we could certainly work on, and that would be more compensatory, focusing on the right hip. We're trying to get the rotation from somewhere else because we're not convinced that we're going to get it from the shoulder. If we are going to try to get it from the shoulder, that would fall more under the category of restorative. We're trying to normalize the shoulder range of motion versus trying to get some mobility from somewhere else. The reality is most patients is going to be some mix of both. We're going to do some restorative work, and we're going to do some work compensatory in nature. We might get into the thoracic spine in that shoulder patient and find, hey, there's some limitation here. Maybe we can get a bunch from there. Or, hey, this person has a ton of rotation coming from the thoracic spine. Great. Let's teach them how in their swing to use that instead of trying to get it from their shoulder. There's a lot of different ways to think about this and a lot of appropriate ways to go about helping these types of patients. Like I said, the biggest thing is assess, don't guess. Make sure you're looking at the individual. Make sure you've gathered all the information, because that's going to be what guides what's going to be the best approach for that person. If you didn't look at the hip or the ankle or the thoracic spine, you wouldn't know that maybe there's a pretty solid answer here versus trying to hammer away at external rotation for somebody who's just not likely to get it, or who finds that their shoulder gets really irritable by being forced into that position. So these are things that we definitely need to make sure that we pay attention to and think about when we are evaluating these patients. Like I said, we're going to talk a little bit more about this in the lab component, but I think it's useful to just have a general idea of the mindset and approach that is going to work best for treating these types of patients.
Interventions for racket sports are going to be pretty similar to golf, so we need to be looking at the bigger picture. So of course we're addressing the symptoms our patient's presenting with, but we also need to address any issue that may be contributing towards the patient's symptoms. So are there any muscle imbalances, joints with limited mobility, or are they unable to dissociate their upper extremity and lower extremities? So interventions are going to be multifaceted. We need to be able to address any and all issues that may be contributing to their injury.
Next, we're going to talk a little bit about injury prevention for golf. Now, it's not likely that many of us are going to see a meaningful amount of patients who are coming to us like, oh, I'm not hurt, but I don't want to get hurt kind of thing. We just don't do that. That's not the way the system works. But as we are finishing up an episode of care with a patient who came to us with an injury, we should be thinking about this a little bit and making sure that, that patient doesn't have to come back and see us with the same thing or something else. There are a number of different programs geared towards injury prevention for golfers. There is no proven gold standard. There's kind of weak research on a whole bunch of different programs. GRIP is one of them, 4 Plus, and 4 Plus Advanced. All of those are aimed at different skill and ability levels. Nothing jumps out as being like, okay, this is the best route to go. I'm not going to go too deep into discussing each of those programs. If you're interested, by all means, go ahead, look them up. There is some interesting stuff there, and I think some concepts that are likely to work very well, at least from an injury risk reduction perspective. Now, I think the area where we can draw some conclusions and can help guide how to make sure that those patients don't have to see us again are looking at other sport literature and what tends to work as far as injury prevention in other sports. And the bottom line is it's preparation for the unique demands of that sport. We've talked quite a bit about the unique demands of golf and where things tend to break down. So, we're probably looking at the hand and wrist, the elbow, and the spine. How do we prepare those muscle groups and joints for the demands of golf? And that's the question that we need to ask ourselves in order to put something together that's going to help with injury prevention. We need to be looking at, for the lumbar spine, we're talking about rotation. We need to make sure we have enough rotational mobility above and below there to make sure that there's not undue demand placed on the lumbar spine. We need to talk about strength and explosiveness. We need to be prepared to swing at near max effort up to, over 100 times in some cases over the course of an 18-hole round. So we need to be prepared for those high effort type of events. There's going to be a lot of strength and explosiveness training that is going to help make sure that our body is up to those types of demands. For the elbow, there's a ton of grip. There's a lot of pronation supination. We need to maintain wrist flexion extension angles. So a lot of strengthening and stability work is going to go a long way for the elbow, hand, and wrist. So those are just some things to think about as far as prevention goes. A lot of different ways that you can do that. But I think the best way to approach it from a mindset perspective is to have in mind what are the demands. Let's prepare the body to meet those demands and not be overworked or overused. Because like we discussed, the vast majority of injuries related to golf are overuse type injuries.
Now, when looking at how to prevent injuries when playing racket sports, it's important to integrate these key components into someone's exercise regime. So firstly, squats are going to be crucial to achieve that explosiveness needed when playing tennis. Next, we have trunk rotations, which is going to help to strengthen and mobilize the mid and low back. And this will help to prevent injury, whether it be overextension or a strain. Scapular stabilization exercises are going to be essential for overhead shoulder stability with those repeated overhead strokes. Shoulder and wrist co-contractions are also important to integrate, as wrist strengthening will decrease likelihood of developing elbow or wrist tendonitis. Specifically, brachioradialis strengthening is super important to help unload the ulnar wrist and prevent any wrist tendinopathy over at the ulnar side of the wrist. And then we have core strengthening. That's going to assist with balance, rotation, and coordination. And then lastly, in order to prevent ankle sprains, which are the number one injury related to tennis, it's going to be important to stretch, wear proper footwear, and potentially use an ankle support or brace if needed for added stability while playing.